The topic we're discussing now is HIV, okay, human immunodeficiency virus. Now, close to around 40 million people are living with HIV across the world, and you can see the percentages over there. A major chunk of these 40 million actually are located in Africa, and the remaining are distributed across the world. India has around 2.4 million people in the 2017 statistics. That is the amount of people living with HIV in India. In India, if you see state-wise distribution, you will realize that the highest percentage per population, the prevalence we are talking about, is in Mizoram, followed by Manipur, then Nagaland, Telangana, Andhra Pradesh. So these are the top 4 or 5 states where per population, if you see, the highest number of cases of HIV are there. Being large states, Andhra, Telangana combined and Maharashtra overall contain high number of cases of not per population, but because they are large states, they contain significant number of cases of HIV. Being an infection, the mode of transmission becomes important. The mode of transmission in HIV is either vertical transmission, that is going from mother to offspring, or this is horizontal transmission. In horizontal transmission, the transsexual route by far is the most common mode of spread across the world, transsexual. The other modes include IV drug abusers, sharing needles, healthcare workers with needle stick injuries, blood transfusions. So these are the other ways of how HIV can spread. So basically it's 2 modes, vertical transmission and horizontal transmission. And then in that horizontal you have transsexual, IV drug abusers, needle stick injuries and blood transfusions. I'm sure you are all aware how HIV is not spread. So it doesn't spread through kissing, hugging, sharing food, insect bites, toilet seats, bathing, sneezing, sweating. These are not the ways how HIV can spread. Definitely it can spread through the transsexual route, whether it is homosexual or heterosexual. It can spread vertically, as I told you, from mother to baby. It can spread sharing equipment, injecting equipment, either the IV drug abusers or healthcare personnel who have needle stick injuries, and ultimately you have a small risk in blood transfusions. Although if you look at the risk of transmission per single exposure, a transfused blood which is HIV positive obviously has got the highest risk. But then now we have such good labs, and definitely blood transfusion is given in a very good standardized, via blood banks. So generally the risk is almost negligible over there now because of all the testing that we're doing before transfusing blood. But among the remaining parameters, you'll see that the highest risk you can make out seems to be coming for the receptive anal intercourse. Okay, not the insertive, the receptive anal intercourse has got the highest risk. And following this, you have the needle sharing. And needle sharing, IV drug abusers. Don't forget, this is not healthcare workers. Healthcare workers, the risk is quite less. It's around 0.3%. That is needle stick injury is 0.3%. But needle sharing with IV drug abusers, that risk is significantly there. It is around 0.6%. This is what I was telling you. Healthcare personnel, around 0.23% or around 0.3% is generally what is accepted across the various references. Receptive vaginal intercourse, on the other hand, is definitely lesser than receptive anal intercourse. So that means if you look at, the highest comes from the receptive anal intercourse. Then the next highest is basically people who are sharing needles in IV drug abusers. And third comes mucous membrane if it is broken. Those are all the various risk factors. So this is a chart showing about the risk of HIV infection by a single exposure. As I told you, if the blood in blood transfusion, if it is HIV positive, then obviously the risk is very high. But then, as I said, we do have now thorough checking, a lot of tests before we transfuse blood. So apart from this, now you do realize that the highest risk is going to be receptive anal intercourse. And this is a question that they ask in an exam. Obviously, in the choices, blood transfusion is not there. Is it receptive anal intercourse? Is it insertive intercourse? Or is it vaginal receptive? Which is the one that has got the highest risk? That's a question that they ask, and the answer is receptive anal intercourse, and you can see is quite high. It's 0.5 to 1%. Following this, you have the others, in which you have needle stick is around 0.3%. Then you have the vaginal receptive is around 0.1%. Now remember that the insertive intercourse, the risk is quite less, meaning the transmission risk from, for example, in heterosexual from male to female is higher compared to female to male. That's one important aspect that you need to understand from this. Okay, so male to female, the risk is higher transmission. So male can easily transmit to female. For the female to transmit to the male becomes less. The risk is comparatively quite less. In vertical transmission, as you can see, it's around labor, that is intrapartum, that the maximum transmission risk occurs from the the mother to the baby. So for this, we are now trying to reduce the risk significantly by starting highly active antiretroviral therapy. We are trying to use cesarean section. We are trying to reduce the exposed blood from the mother to the baby. So we are trying many things that is significantly reducing the risk of vertical transmission. As you can see, the intrauterine transmission is 20%. Then you have the postpartum through breastfeeding and other ways, that is 30%. But the maximum risk seems to be around the time of labor, that is intrapartum. Coming to the HIV virus proper. This belongs to the Retroviridae family and the lentivirus group. Okay, so this is a lentivirus. If you look at the structure of the virus, this is an RNA virus which has got a lipid bilayer. It's got a matrix protein. Inside this is the core protein, which contains the two strands of the positive sense single-stranded RNA. So if you look at the hallmark features of this virus, in its structure you will see that there's a transmembrane pedicle which is there. This transmembrane pedicle is attached to a surface spike protein. This surface spike protein is referred to as GP120. Okay, the surface spike protein is referred to as GP120. The transmembrane pedicle is referred to as GP41. Okay, this transmembrane pedicle is referred to as GP41. The spike protein is GP120. The inner, just below the double layered membrane, is the matrix protein, which is also referred to as GP17. Okay, this is also referred to as a matrix protein. So GP120 is the spike protein. GP41 is the transmembrane pedicle. Then you have the core protein, which is referred to as the GP24. Okay, this is the core, which basically contains the RNA, which as I told you, the positive sense RNAs, and these are single-stranded RNAs. So this is in brief about the structure of the HIV virus. You can also see the actual image, and you can make out here that this is a bilayered lipid membrane. First of all, this bilayered lipid membrane has got a number of spikes coming out of it, and these spikes are what I told you are nothing but GP120. The transmembrane pedicles we just discussed is nothing but GP41. Inside this you have the GP17. The GP17 is basically the core protein, the matrix protein, sorry, and then within it is the core, and the core is nothing but GP24. The core obviously contains the RNA. So to summarize once again, we have the spike protein, which is the GP120, the transmembrane pedicle, which is GP41. We have the double membrane lipid layer. Inside this, we have the matrix protein, that is GP17, which is the matrix protein. Then you have the core or the capsid protein, better referred to as the capsid, which contains the RNA. So these are in brief about the structure. Now this HIV virus, the way it enters the cells is interesting. If you look at the cell has got a CD4 receptor. Okay, it's got the CD4 receptor. The CD4 receptor, there are many cells that contain CD4 receptors, particularly the T helper cells, the macrophages, the microglia in the brain, the dendritic cells. All these contain the CD4 receptors, and they are all targets for the HIV virus. So the HIV virus, the GP120 that is there, plays a very important role in docking onto the CD4. So the GP124 is the main docking spike protein that attaches to the CD4 receptor. So the first contact is made via this GP120, and then once it touches it, it's able to undergo a transformational change, and it also has to have a co-receptor to help its attachment to the CD4, and that co-receptor that is there for its attachment to the CD4, this co-receptor that should be there, this co-receptor is CCR5. Now there are two major co-receptors that one should be aware of. One is known as the CCR5 and the other is known as the CXCR4. In most of the CD4 containing cells, particularly the T cells, what you get is the CXCR4. In the macrophages, you get the CCR5. Now, some cells can have either CCR5 or some of them can have CXCR4. The HIV virus, the GP120, is in the sense there are many strains in the HIV virus. And in this GP120, some of them can attach to CCR5, some of them can attach to CXCR4, some have the capability to attach to either of them. So let's look at the co-receptor, that is the CCR5, and the CCR5, which is predominantly present on the macrophages, and the CXCR4, which is predominantly present on the T cells. So this, let's say, is a macrophage, and you're looking at the CCR5, and this helps this GP120 undergo the transformational change and also makes contact with the CCR5. The combined CD4 and the CCR5, the GP120 is able to attach to. This brings about a transformational change in the conformation of the protein, and that allows the GP41 to be able to attach and create a fusion so that entry of the virus is possible. So it is the GP41, which is a transmembrane pedicle, which is really required for the virus to enter inside and create a fusion molecule. So to repeat once again, GP120 makes contact with the CD4. It needs a co-receptor. The co-receptor is the CCR5 in the macrophages at least. Once the attachment to the CD4 and CCR5 happens, then you find that the GP41 is involved in creating a fusion. So this GP41 allows the virus to start attaching its membrane to the membrane of the macrophage, for example, and that ultimately creates a fusion molecule. And once a fusion of the virus happens, once a fusion happens, it is able to allow the inner contents, that is the capsid, to be released inside. So this is how the virus is able to attach to the cell, and this is how it's able to release its the genomic content inside into the cell. If you look at the HIV genome, it's got three main structural genes, which is the GAG, the POL, and the ENV. Okay, GAG, POL, envelope, that is ENV. And then you have regulatory genes, which include TAT, MEF, REV, VIF, VPR, and VPU. So these are all referred to as the regulatory genes. So you have the three main structural genes that are there and in the genome, and apart from that you have the regulatory genes, which include the TAT, NEF, REV, VIF, VPR, and VPU. If you look at the GAG, this codes for something called the P55, which actually gives rise to the P17, which we discussed earlier as the matrix protein, and the P24, which is the capsid or the core. The POL is basically the pool that contains the enzymes, and this pool is basically the reverse transcriptase, the integrase, and the proteases. Okay, so these are nothing but the reverse transcriptase enzyme, the integrase, and the protease. The ENV is basically GP160 and gives rise to the two main proteins, the GP120 and the GP41. As we already discussed, GP120 is the spike protein and the GP41 is the transmembrane pedicle. So all these are the structural genes. So each of these genes has got a job to do, and that is it codes for all these structures. If you look at the regulatory, the TAT basically helps in elongation. It basically increases the activity of the RNA polymerase, whereby it causes elongation of viral genome. NEF, one of the major things that NEF does is it prevents the expression of MHC class 1. Remember, all nucleated cells have got MHC class 1 and antigen presenting cells have got MHC class 2. The MHC class 1 expression is very important in presenting part of the virus to the external environment to suggest that the cell is infected. So if the outside immune system is not aware that the cell is infected, then obviously the expression of the part of the virus to the outside world, to the immune system, that this cell is infected has to come through MHC1. NEF does not allow expression or, so if this is the virus, if this is the cell which contains the virus inside, the cell has to express the MHC class 1 to the outside immune system to tell that this cell is infected, so that the cytotoxic T cells can attack the cell and destroy the virus inside. Now that expression of MHC class 1 to some extent is downregulated. It is suppressed by the NEF. So decreases the expression of MHC class 1. REV inhibits the viral RNA splicing. This inhibits the viral RNA splicing. VIF is the viral infectivity factor, and this increases the infectivity of the virus. The VPR facilitates the HIV virus infection into the macrophages, and the VPU helps in the virion release. So it seems like a very sophisticated system which got all this armamentarium to help it to proliferate, to be able to evade the immune mechanisms of the body, and to be able to elongate and spread and increase the infectivity. So this is all the various components of the important components of the genome that you should be aware of. Most importantly, you should know about the GAG polenv. The GAG basically gives rise to the matrix and the capsid. The pol is the pool of the enzymes. The pool of the enzymes are RIP. This is reverse transcriptase, integrase, and protease. The N is the envelope, and this contains the GP120, which is spike protein, GP41, which is transmembrane pedicle. The regulatory genes are the TAT, which helps in elongation of viral genome, NEF, which decreases MHC class 1 expression so that it can evade the cytotoxic T cells. REV inhibits the viral RNA splicing. VIF is viral infectivity factor, increases the infectivity of the virus. VPR facilitates infection of macrophages, and VPU helps in the virion to be released from the virus so that more progeny viruses can be released easily. If you see how the virus is able to enter inside the macrophages and the cytotoxic T cells, the helper T cells, and how it's able to enter inside the dendritic cells, the subunits of the macrophages and the monocytes. So what I'm trying to tell you is basically to understand the life cycle. So this is a very nice image depicting the way how the virus is able to enter inside the cells. So if you look at the way, you can make out that, as I told you, this is basically the spike protein, which is the GP41, which has a very important role in attaching to the CD4 receptor. You can see here the GP120 are able to attach to the CD4. This, in addition, needs to activate a co-receptor, and this co-receptor you can see is the CCR5 or the CXCR4. The CCR5, as I told you, is predominantly located on the macrophages. The CXCR4 is predominantly present on the T helper cells. This co-receptor plus the CD4, which is red over here, the combined attachment helps the transmembrane pedicle, that is GP41, to come into action. And this is able to create the anchor. And this GP41, the way it's able to create this anchor, allows for the virus to throw its contents inside. Once the inner core is released, which contains the RNA and the variety of enzymes required for the RNA to start replicating, you can see here one of the things it carries within itself is the reverse transcriptase enzyme. From this, the single-stranded RNA that is there, it's able to create from the RNA a DNA template, and that DNA, it's able to create one more so that you get a double-stranded DNA ultimately. So you have the RNA that is released from here. The RNA is able, because with the help of reverse transcriptase enzyme, it's able to convert the RNA into the DNA, and a double-stranded DNA is very soon formed. And this double-stranded DNA is able to enter inside the nucleus. And once it enters inside the nucleus, the integrase helps. The integrase helps in its getting incorporated in the host DNA. So the host DNA is there, and then in this, the viral DNA is incorporated. The enzyme that is going to play a role in this is integrase. The integrase helps the viral DNA to get attached to this, and once it's become the part of the host, it starts transcription, translation. It starts producing the proteins. Now, whatever proteins produces is one elongated protein that has to be cut into its proper components, and the job of that is done by the proteases. So you can see here a sequence of steps that are there that are involved in the way how the virus enters. The detailed analysis of how the virus is able to enter inside and replicate has given us an idea about where all we can use drugs that can prevent the virus from replicating. So we have a variety of drugs now, and we'll discuss in detail about the targets where the virus, the antiviral drugs, the highly active antiretroviral therapy that is there, where all it is targeting. So those targets, to be able to understand that, one should be aware of how the virus enters inside and how it is able to replicate and how it is able to release the further progeny virions. So you can see here, there's another diagram explaining the same thing. It's the same stuff. You can see the GP120 attaching to the CD4. The co-receptor CCR5 or CXCR4 helps a role in the transformational change in the GP120. Once that these two come into contact, the CD4 and the CCR5 to the GP120, the GP41's job begins. The GP141 allows for the fusion to form. Once the fusion occurs, the virus is released. So this is how the RNA from the virus is released inside the cell. This virus is carrying its own enzymes to convert or create the DNA from the RNA. That's why it's called reverse transcriptase. So it reverse now creates the DNA, and the DNA that is formed is able to get incorporated inside the host DNA with the help of the integrase. The proteins that are coming out are properly spliced and arranged with the help of proteases. That is also an enzyme that this virus is carrying. So the three important enzymes, that means the reverse transcriptase, the integrase, and the protease, are efficiently working in allowing the RNA to convert to form the DNA. The DNA gets incorporated in the host genome, and that DNA produces the proteins which are nicely spliced by the protease enzymes. Ultimately, the packaging of the new virion starts occurring, involving part of the membrane of the host cell, and over a period of time multiple viruses, as they bud out of using part of the host membrane, the lack of membrane itself will allow the cell to get destroyed. So ultimately you will see that the cells get destroyed. Now the destruction of the cells, including macrophages, the dendritic cells, the CD4 cells, is not just because of the replication, there is loss of the membrane, but there are other factors which include apoptosis, pyroptosis. There are other mechanisms through which you will see overall these cells start becoming decreased in number, and this decrease in their numbers allows for the opportunistic infections, because all these cells, the macrophages, the CD4 cells, the dendritic cells, play a very important role in activating the adaptive immunity, and if they are suppressed, then obviously you will see opportunistic infections become a problem. So one of the core issues that HIV does is hits the immune system, and because it hits the immune system, you will see opportunistic infections start becoming a problem, and that's how ultimately you will see that the body is swamped with multiple infections and multiple problems will start occurring. It was seen in some populations that there is a mutation called the delta 32 mutation, and because of this delta 32 mutation, the CCR5 was not there. In some people, the CCR5 expression was not happening. In the absence of CCR5, as you can understand, the combined GP binding of the CD4, the CCR5 along with the GP120, then only you are able to see the GP41 is able to create the fusion, and that's how the entry of the virus can occur. So those people who are not having the CCR5, they are found to have resistance to the HIV virus. So CCR5, sometimes you see that this is the expression of CCR5 may not be completely absent but reduced, and those people in whom the CCR5 expression is reduced, those people also tend to have a decreased amount of HIV viral load, and rather the progression towards AIDS becomes significantly very less. So this is nothing but the delta 32 mutation. The CCR5 co-receptor signaling is not happening, the attachment is not happening. Without the CCR5, the patients become resistant to HIV. So this gave us an idea that we could use drugs that can help in blocking the CCR5, and by the drug that we have got now that is able to block CCR5 is called Maraviroc. Okay, so we do have a drug now that is able to attach to the CCR5 and make it non-functional, and this drug is referred to as Maraviroc. We also know that the entry of the virus into the cell is basically driven by the GP41, which creates the fusion, and that's how the fusion of the virus to the membrane of the invading cell happens, and that's how you are able to see the channel created and the viral contents are thrown inside. So this is basically the entry of the virus into the cell via GP41 is referred to as fusion. So we do have something called fusion inhibitors, and in the fusion inhibitors we have the enfuvirtide. Okay, so this is referred to as a fusion inhibitor, and this is known as enfuvirtide. So basically what I'm trying to suggest is that if you understand how the virus is able to enter inside, we know now the targets that we can try to attack so that the entry of the virus inside the cell is inhibited. So one I told you already, the CCR5 blockers, Maraviroc, the GP41 induced fusion that is there, that can be blocked by the fusion inhibitor, and that is nothing but the enfuvirtide. Then we have the three enzymes that are released inside, and those three enzymes are the reverse transcriptase, the integrase, and the protease. So we are trying to block the function of these, and reverse transcriptase we are able to prevent its work by giving nucleoside or nucleotide analogs that do not allow elongation of the chain. So we have nucleotide reverse transcriptase inhibitors, we have the non-nucleoside, the nucleotide reverse transcriptase inhibitors, the non-nucleoside reverse transcriptase inhibitors, all those are there. So they're all working to prevent the formation of the DNA. That DNA that is formed should not get integrated in the host DNA, and that job is done by integrase. So we now have integrase inhibitors. Whatever integrated host the DNA that is integrated in the host, continues to produce the proteins. The proteins have to be cut into right place so that they can form the subcomponents of the virus. This requires protease. So we are able to block this proteases now, protease enzyme, so that the cutting of the protein to form the viral particles does not occur. And that's why we also have protease inhibitors. So you notice then each of the steps where the virus is using to replicate, we are trying to block those so that the virus is able to get suppressed. And although we can't get a 100% cure because the virus has become part of the host DNA already, but we can significantly suppress the viral replication and the amount of damage that the virus is able to do. This explains why HIV now is to a large extent the overall survival in patients who are suffering with HIV is almost similar. Those who are getting access to good treatment, the survival is almost as good as a normal person. So we already discussed what the virus does. It's able to penetrate into the immune cells, the major cells that control the immune system for us, and incapacitate them. So what is the natural history of this disease? The incubation period roughly is around 1 to 2 weeks, and the virus starts becoming detectable in the blood in around 1 to 2 weeks. In fact, as early as 12th day, we do have now RT-PCR that can pick up the RNA in the blood. So basically, virus becomes detectable by about 1 to 2 weeks. That is roughly around 12 days. We have the RT-PCR becoming positive. If you look at the seroconversion, that is the formation of antibodies, this starts occurring in about 6 to 12 weeks. And the virus starts getting restricted to the lymphatic system, the reticular endothelial system, and it significantly decreases in the plasma for quite some time. And this is some kind of a seroconversion that occurs in about 95% of patients. Symptomatic disease might take anywhere between 2 to 15 years, and on average, it takes about 9 years for a patient to start developing symptoms. However, there are a significant set of patients who can develop something called the acute HIV syndrome or the acute retroviral syndrome. Not all patients who get exposed to HIV develop the acute HIV syndrome. It happens to occur in about 40 to 60% of patients who can develop an acute HIV syndrome. This is nothing but a febrile illness. Many times, even though patient develops this acute HIV syndrome, nobody suspects the patient to have HIV, and most of the times it goes undetected and supportive symptomatic treatment is given, and many times the patient is not investigated appropriately and not detected to have HIV. So this acute HIV syndrome, as I was telling you, can occur anywhere between 40 to 60% of patients, of the acutely infected patients. The main thing is going to be it's a febrile illness, so fever is a hallmark of this condition. Apart from fever, which occurs in more than 90% of those people who develop this, there is lymphadenopathy that can occur, pharyngitis, resulting in sore throat. The combination of fever, lymph node enlargement, and sore throat makes it look like infectious mononucleosis. It kind of looks like infectious mononucleosis. So many times, this is the important thing, that whenever you see a patient presenting, an adult between the ages of 20 to 50 years presenting with infectious mononucleosis-like features, it is very important to suspect the possibility of HIV and test for HIV. So fever, lymphadenopathy, pharyngitis, that is sore throat, can occur. Some of these patients can develop a rash. This rash generally is an erythematous maculopapular rash, which occurs on the face and the trunk. There could be mucocutaneous ulceration, mainly involving the mouth and the esophagus, sometimes involving the genitals. Myalgia, arthralgia, like any viral infection. GI symptoms are known to occur in about 50% of patients. Weight loss can occur, headache, and about 1/4 of patients, that is 25% of patients, can develop aseptic meningitis. So these are all the ways how an acute HIV syndrome can manifest. To summarize then, patient got infected and a few days later start developing a febrile illness, which is generally confused with a viral, nobody really suspects it's HIV. It looks like an infectious mononucleosis-like picture. You got fever, lymphadenopathy, sore throat, and a rash. The rash is a maculopapular rash, typically involving the face and the trunk, might involve the extremities. You can get ulcerations in the mouth, esophagus, or genitals. Some non-specific myalgia, arthralgias can occur. About 50% of them can develop GI symptoms. Weight loss can occur in a significant number of patients. It's a common symptom, actually, weight loss in this viral problem. headache can occur, and about 25% of them can develop aseptic meningitis. So these are all what constitute the acute HIV syndrome, and one should suspect the possibility of HIV. The higher the index of suspicion, the higher the likelihood that HIV can be detected. Unfortunately, a significant number of patients pass through the acute infection, and you can see here that the initial few months we're talking about is when the acute infection is going to occur. Okay, there's the acute HIV infection. But I told you the acute HIV infection doesn't occur in 100% of patients. It does occur in a significant number of them, 40 to 60% and up to 80% in some studies. Acute HIV infection can occur. During this phase, you can see that the CD4 counts, this dotted line is a CD4 count. The blue line is the HIV antibodies. That is some kind of seroconversion that does occur. And then this is the viral load. Notice that there is an initial significant viral load that is there, and this is the reason why you'll find that HIV RNA PCR basically becomes a very important tool in the diagnosis when you're suspecting acute HIV syndrome. It's a very important tool because the number of copies of HIV will be very high. Usually more than 10,000 copies of HIV will be there in the blood. So what you're noticing is this acute infection. If one is able to test, then obviously you can have an early diagnosis of HIV. After that, what happens is that there's prolonged asymptomatic stage that can last from months to up to 5 to 6 years. And then after that, only the symptomatic stage can start. And you can see that the viral load keeps on increasing subsequently after that, and the CD4 count keeps on dropping. The lower the CD4 count, it correlates with the development of opportunist infections and AIDS-related malignancies. And ultimately, the patient is able to develop stage 3 disease, which is basically very low CD4 counts. And that's how we get the AIDS syndrome. So what is the reason why you get the initial acute infection? You do see the CD4 counts are decreasing, the viral load increases, but subsequently after that you notice that the virus significantly decreases. In the green line you can make out in the asymptomatic stage the virus is significantly low number of copies in the blood, and the reason for that is explained nicely in this chart in Harrison. You got a primary infection, you got the acute syndrome, and this is about 3 to 6 weeks you can get the acute syndrome. So there is a plasma viremia, wide dissemination of the virus occurs, the acute syndrome happens. And then you do have, as I told you, the retrafficking of lymphocytes. So all these result in the acute syndrome. About 1 to 3 months later, the patient develops an immune response to HIV, and you have the curtailment of the plasma viremia. So you can see the plasma viremia starts decreasing. So basically the virus is banished into the lymphatic circuits and it's not allowed in the blood. There's an establishment of a chronic persistent infection in the lymphoid tissue. And the surprising thing is, even though it is restricted to lymphoid tissue in this zone, it is able to replicate quite nicely inside over there. And it develops a clinical latency, which will start showing its face with opportunistic infection and other problems many years later. So this is what happens in the acute HIV syndrome. To summarize then, you got an acute HIV syndrome, the virus got exposed, the patient got exposed to the virus was able to enter inside the macrophages, that is the monocyte derivatives, which includes the macrophages, the dendritic cells, the microglia, all the monocyte derivatives. It is able to percolate into those cells. You have the virus entering into the CD4 cells, which is the big problem because CD4 cells contain a significant part of the adaptive immunity. So it's able to suppress the immune system. There is a viremia happening in the blood. There is retrafficking of lymphocytes. Ultimately, you find the acute syndrome occurring. This is what I was discussing up till now. That is the acute febrile HIV syndrome. A few months later, the patient starts developing immune response, and then it goes into a kind of latency where the viral load in the blood is decreased. There is a curtailment of plasma viremia. There is establishment of a chronic persistent infection in the lymphoid tissue. And then after many years later, the patient will start showing the clinical symptomatic stage of HIV. So that is what we refer to as chronic HIV. So I hope you understood the significance of the acute HIV syndrome. And then you have the asymptomatic phase, and then you start developing the symptomatic HIV, chronic HIV phase. If you look at the stages of HIV, we do realize that the number of CD4 cells, the CD4 count is very important in controlling the, maintaining the immune responses against opportunistic infections. So to a large extent, the stage is built on the CD4 counts. If you look at the stage 1, this is the CD4 count that is more than 500 or more than 26%. Stage 2, the CD4 count is 200 to 500. Okay, 200 to 499 to be precise. So it's between 14 to 25%. In stage 3, the CD4 counts are less than 200, or they're less than 14%. So sometimes they'll ask in the percentages, sometimes they'll ask for the CD4 counts. You should know what stage 3 is. Stage 3 is the important thing among this. Stage 3 is when the CD4 counts are less than 200 or they're less than 14% of total. Okay, so less than 200 CD4 counts is stage 3 and less than 14% in adult is stage 3. Obviously in children these numbers are different, so they don't ask about children on exams, so you don't have to worry, but you should know about the adult staging based on the CD4 count. As I was explaining to you that the CD4 counts, that means have a clear way of showing to us about how the patient's clinical manifestations can be. As you know, the lower the CD4 count, the more the symptomatic manifestations of chronic HIV will start becoming obvious. So if you look at the CD4 count, less than 500, initially the patient might be asymptomatic. Constitutional symptoms might start. This includes fever, night sweats, fatigue, weight loss can occur. The patients can develop mucocutaneous lesions like seborrheic dermatitis, herpes simplex, varicella, that is shingles can occur, oral hairy leukoplakia, candidiasis, recurrent bacterial infections, pneumonia. So all these things can occur in the stage 1, that is between 500 to 200. In the stage 2, that means we are talking about the 200 to 500 range. This is what you can expect, this between 200 to 500 range. When it is stage 3, that is less than 200, these are the infections that start becoming a problem. This includes the pneumocystis jirovecii pneumonia. The patient can develop Kaposi sarcoma, oral thrush, then fungal infections like Cryptococcus neoformans can occur. So all these start becoming a problem below 200. Below 100, you will see the progressive multifocal leukoencephalopathy and toxoplasmosis. And below 50, you will see CMV retinitis and Mycobacterium avium complex. So these two are the most important ones. You should know CMV retinitis particularly, and Mycobacterium avium complex become more important below 50. So to summarize once again then, based on the CD4 counts, you can expect the infections. So basically I told you stage 1 is above 500, stage 2 is between 200 to 500. So more or less in stage 2, these are all the things that can occur. Okay, these include the manifestations like skin manifestations. You can have Kaposi sarcoma, you can expect pneumonia, pulmonary tuberculosis, all these things can occur. These are all between 200 to 500. Less than 200, pneumocystis pneumonia becomes important, Kaposi sarcoma more common, thrush can become more common, more fungal infections becoming problem. Less than 100, two important things, CNS problems, leukoencephalopathy as well as CNS toxoplasmosis. And less than 50, we see retinitis, that is CMV infections, and Mycobacterium avium. These are the important things to remember below 50. So this numbers and based on the CD4, for example, if you see an MCQ giving you a CD4 of say 10 or 20, you know they're talking about Mycobacterium avium or CMV retinitis. If they're telling you a CD4 count that is 150, they're trying to tell you that pneumocystis pneumonia becomes an issue. So basically the CD4 count gives you a rough idea in which territory they are and what infections they are trying to drive towards. This is another chart that is nicely explaining the relationship between the CD4 count, the viral load, and the duration, and what are the things that can happen. Remember that the initial infection happened over here. This is the initial point of infection. And then after some time, you'll see the virus starts becoming detected. I told you that the RT-PCR can pick up the virus as early as 12th day. That is about 2 weeks time. The PCR can pick up the viral copies. You do notice a significant rise in the HIV viral copies in the initial phase, the acute HIV syndrome I was telling you about. There is a dip in the CD4. Although opportunistic infections do not occur at this time, but the patient can develop the variety of features which are basically febrile illness along with infection mononucleus like picture. That's the acute HIV syndrome. Then there is a phase where you find that the viremia is curtailed, some kind of seroconversion starts occurring, and you do see that the CD4 counts that are there. Okay, so this is the viral level, and you do notice that the CD4 counts are well maintained in this phase. So this is the CD4 on the y-axis, and you can see that the CD4 counts are pretty well maintained during this phase. And at this time, when the CD4 counts are maintained, you do notice that there is a risk of developing pneumococcal, other bacterial infections, candida vaginitis, ITP. These things can be a problem that the patient can present with. Over a period of time, you notice this brown line starts declining, and this is the CD4 counts that are declining now. As the CD4 count starts declining, then you see a variety of problems start occurring. Although tuberculosis can occur at any CD4 count, but it starts becoming more, that means the reactivation of TB starts becoming an impending, inevitable scenario if patient is exposed to TB Obviously, the reactivation can occur. So TB becomes an issue as the CD4 count decreases. Kaposi, sarcoma, oral thrush, hairy leukoplakia, lymphoma, all these start becoming increased. You do notice that there is a risk of developing persistent generalized lymphadenopathy around this point, and you also see other infections like Candida, esophagitis, herpes simplex, Cryptococcus. All these things start becoming more significant as the CD4 counts starts decreasing. So you notice then initial 4 to 8 weeks we're talking about acute HIV syndrome. In the asymptomatic phase, which can last up to 12 years sometimes, you don't notice much except for some pneumonias, Candida vaginitis, ITP. These problems can occur. Then much later you start noticing symptomatic phase, and in the symptomatic phase you can get all these opportunistic infections. Sometimes you get a persistent generalized lymphadenopathy. So all these are problems that can occur. As you can see, this side is the viral load, and this yellow line is representing the viral copies. So that means there are 2 times that the patient can present to us. He can come with the acute HIV syndrome. We need to suspect, have a high index of suspicion, and investigate and get the HIV testing done. How to investigate for HIV, I'll discuss in a few minutes. The second scenario is the patient may present to us later, much later, with symptomatic phase starting, and that is chronic HIV now. Now, what are the clues that will tell you that this patient might be having HIV and he must be investigated? The clues are, if any patient develops herpes zoster below the age of 50 years, if patient is developing severe seborrheic dermatitis, psoriasis, if the patient is developing recurrent pneumonias, sinusitis, recurrent sinusitis, or other recurrent bacterial infections, then one needs to have a high index of suspicion and get a HIV tested. Now be careful, in this list oral thrush doesn't come. The presence of oral thrush is not an indication for you to go for testing for HIV. So recurrent pneumonias are there, sinusitis, bacterial infections, seborrheic dermatitis, skin rashes, psoriasis, herpes zoster below the age of 50 years. Any patient presenting with febrile problems like fever of unknown origin, sweats, weight loss, lymphadenopathy, chronic lymphadenopathy. Okay, especially if the chronic lymphadenopathy is without any alternative diagnosis. Any patient developing disseminated mycobacterial infections, sexually transmitted diseases, any patient coming with sexually transmitted diseases, or patients presenting with hepatitis B or C, because Hep B and C, the mode of transmission of them is very similar to HIV. So one should test when you are seeing somebody coming with hepatitis B and C, you should investigate for HIV also. Human papilloma virus, herpes simplex virus infections, any patient presenting with cytopenias, especially if the patient has got low platelets, because one of the problems that patients with HIV can develop is even in the asymptomatic phases, they can develop a picture like ITP. So you have to get the HIV tested. And finally, any opportunistic infections, which we'll discuss now, known as the age-defining illnesses, definitely then HIV investigation has to be done. Okay, opportunistic infections or the age-defining illnesses, Kaposi sarcoma, any of these things if the patient presents with, then they have to be investigated for HIV. So this is a nice chart that kind of gives you an idea about when you should get a HIV test done. Test for HIV in any patient with signs or symptoms of immunologic dysfunction, weight loss, generalized lymphadenopathy, fever, night sweats for more than 2 weeks duration, or somebody coming with severe abscess ulcers, get a HIV testing done. Severe or refractory herpes simplex infections, oral thrush. Oral thrush alone is not enough. The patient should have esophageal candidiasis, pneumocystis jirovecii, cryptococcal meningitis, disseminated mycobacterial infection, CMV retinitis, toxoplasmosis, seborrheic dermatitis, or new severe psoriasis, recurrent herpes zoster infections. All these should click on you to tell, okay, this patient needs a HIV investigation. At the same time, one should be aware of something called the age-defining illnesses. We know that some of these diseases, the opportunistic infections, are so classical in patients with when they develop AIDS, that is the third stage of HIV, that it becomes just the very occurrence of them should indicate to us that they might actually be having an immune compromise problem, which could be HIV. So these are the age-defining diseases where you don't even need the lab evidence of HIV infection. In this list, we have the candidiasis of the esophagus, trachea, bronchi, or lungs. Be careful, candida infection of the vagina or the oral cavity is not an age-defining diagnosis. But candidiasis of the esophagus, the trachea, the bronchi, or the lungs should be there to tell, okay, this patient has got immune compromise problem, could be AIDS. Cryptococcus and extrapulmonary involvement, cryptococcal infection, especially extrapulmonary, not pulmonary cryptococcus, but cryptococcal meningitis or skin involvement, all this should tell that this is a patient who might be having AIDS. Cryptosporidiosis, be careful. You do have a lot of infection that can happen in HIV. It could be isospora or microspora. They're all not listed. Cryptosporidium with diarrhea persisting for more than 1 month. That is a AIDS-defining problem. CMV infection of any organ other than liver, spleen or lymph node. Okay, so CMV involvement of the retina, CMV esophagitis, CMV colitis, CMV encephalitis. So CMV involvement of an organ other than liver, spleen or lymph node. Herpes simplex infection causing a mucocutaneous ulcer that persists longer than 1 month, or herpes simplex esophagitis. Kaposi sarcoma in a patient less than 60 years. Lymphoma of the brain less than 60 years. Mycobacterium avium complex involvement. Pneumocystis pneumonia occurrence. Progressive multifocal leukoencephalopathy and toxoplasmosis of the brain. Each of these by themselves can suggest that the patient has got HIV infection and might be having AIDS, that is stage 3 HIV. So basically, sometimes they do ask AIDS defining illness, and you can understand that people who are immunocompetent, they generally do not develop candidal infection of the esophagus or the trachea. Cryptococcus infection of the lung is possible, but involvement of meningitis, cryptococcal meningitis, or skin involvement of cryptococci, generally these things can occur only in an immunocompromised patient. Same way, cryptosporidiosis diarrhea doesn't occur in immunocompetent people. CMA infection involving the retina or the esophagus or other organs, those things are suggestive of immunocompromised state. Herpes simplex infections lasting for more than a month, causing ulceration or esophagitis of any duration. Kaposi sarcoma below 60, lymphoma of the brain, primary lymphoma of the brain we talk about. Mycobacterium avium, I told you, typically occurs when the CD4 counts are less than 50. So less than 50 CD4 counts include Mycobacterium avium and CMV retinitis. So those two things, and that means the CD4 count must be very, very less for this infection to occur. Pneumocystis pneumonia, CD4 count less than 200, multifocal leukoencephalopathy and toxoplasma of the brain. All these are what we refer to as the AIDS-defining diagnosis. There are some diagnoses, however, where you cannot, even though they are there. For example, you have other fungal infections like histoplasmosis, coccidioidomycosis. They are not listed in this. Infection of coccidioidomycosis, for example, is a fungal infection. Agreed, fungal infections occur in immunocompromised patients, but they are not referred to as AIDS-defining illness. We call them AIDS-defined only if you have HIV serology positive. That means you have to have lab supporting HIV. Then you have coccidioidomycosis, then you say, okay, that is AIDS defining illness, but it's got HIV positivity. It has to have HIV positive. These, even without HIV positive, the very occurrence of them might be a feature suggestive of AIDS case definition, that this patient has to be investigated and they have to go in for surveillance to find out their sexual contacts and to investigate further, but that this could be a potential patient with HIV. Another question that they ask in our exam is the HIV-associated malignancies. Okay, these are referred to as the HIV-related malignancies. In the list of HIV-related malignancies, we have Kaposi sarcoma, non-Hodgkin's lymphoma, lymphoma of the brain, okay, also referred to as the primary CNS lymphoma, and when we have the invasive cervical carcinoma. So these four are referred to as HIV-related malignancies: Kaposi sarcoma, non-Hodgkin's lymphoma, primary CNS lymphoma or the lymphoma of the brain, and invasive cervical carcinoma. Even this is a question that has been asked in the past, so you should know the important cancers that are linked with HIV. The next step is, how do we investigate HIV? Okay, in a patient suspected to have HIV, we discussed already what are the red flags that alert to us that the patient could be having HIV. Now, once you're suspecting HIV, how do you investigate? The current investigation that is recommended for HIV is a 4th generation ELISA test. This 4th generation ELISA actually tests for the P24 antigen, and it also tests for the HIV-1 and 2 antibodies. Okay, so this is the current standard of testing now. You do a 4th generation ELISA, that is, it tests all three things at the same time. There is P24 antigen and HIV-1 and 2 antibodies. Once this test is positive, the next step is you have to do the HIV-1 and the HIV-2 discriminative antibody test. You have to really find out what is it. Is it HIV-1 or HIV-2? So you're going to go for the antibody differentiation test. The important point to remember is earlier what we used to do is get the ELISA done first. Then after that we would go for the confirmatory test for which we used to use the Western blot. The Western blot tests are all gone now. The 2014 CDC recommendation has removed Western blot as the confirmatory test. So this is the new rule now, and this is the new testing that is recommended. You can see how we start. First of all, we do a combined HIV-1 to antigen antibody combination assay. The antigen obviously they're talking about here is the P24 antigen. So P24 antigen and the antibody combination assay. This is known as the 4th generation ELISA. If this is negative, then obviously we are ruling out HIV because this test, the combination of it is supposed to be highly sensitive. Once it's positive, particularly in a chronic HIV, obviously in a chronic HIV, the patient should have one of the two, either the P24 antigen should be there or the antibody should be there. If they're all negative, then obviously this patient does not have HIV because this is reasonably sensitive. Once it's positive, your next step is to look at, is it HIV-1 or HIV-2, and you are going to do the differentiation antibody. Once you analyze, the results could be either the patient's got antibodies against HIV-1, meaning the patient is HIV-1, or you can have antibodies against HIV-2, that means HIV-1 antibodies are negative, HIV-2 antibodies are positive, that means the diagnosis is HIV-2. The patient might be having antibodies for both, that means he's got, both strains involved. Both the strains are infecting this patient. That's a rare scenario. Finally, it could be HIV-1 negative or indeterminate or HIV-2 negative. When both are negative, then the next option that you have to go is for PCR. This is nothing but the nucleic acid amplification test, that is PCR. And PCR is going to tell us if the PCR is positive, obviously it's acute HIV infection. And if it's negative, then we rule out HIV. That means it must have been a false positive test. So let me repeat it once again. What do you start with first? The first thing that we do is the 4th generation ELISA, which includes the P24 antigen and the HIV antibodies, combined test. Any one of them positive, the test will show positive. Once you have all these negative, you can rule out the diagnosis. This means because this is pretty sensitive test. But you still have, because don't forget, any disease that has got a low prevalence, if a test is positive, and let's say the prevalence is very, very rare, the disease is very rare, the possibility of the test being false positive is still there. So if it's negative, we have ruled out HIV, fine. But if it's positive, we still have to investigate. And we are now looking at, are the antibodies, see, we did a combined test. Now we don't know the antibody, which of these is the reason why the test became positive. Maybe it's P24 antigen, maybe HIV-1, HIV-2 antibody, we don't know. Now we are specifically testing what the patient actually has got. We are now looking at, is the patient having HIV-1 antibodies and no antibody against HIV-2? That means the patient has got HIV-1 infection. Does he have antibodies against HIV-2 and not against HIV-1? That means he's got HIV-2 infection. Does he have antibodies against both? That means he's surprisingly got both the strains getting, he's infected by both the strains. Possible. But supposing he's got HIV-1 negative and HIV-2 negative or indeterminate, that means the next step has to be a PCR. Now the PCR, if it's positive, then obviously confirmed does patient not HIV. And if it's negative, the patient does not have HIV. That means it must have been a false positive test. One important idea to understand is that once you have the 4th generation ELISA showing positive, you did the differentiation immunoassay, you ended up in this position, that is HIV-1 negative, HIV-2 negative. Now the next step obviously by sequence is to go for an PCR, isn't it? That nucleic acid amplification test, which is nothing but PCR. Now you did not get antibodies against HIV-1, did not get against HIV-2, or they are indeterminate. The next step is supposed to be PCR, which is confirmatory. Now sometimes I've seen a question being asked in the exam, supposing the 4th generation ELISA was positive, the patient did not show antibodies against HIV-1 or 2, that means it's neither HIV-1 or HIV-2. The next step obviously is PCR. But before doing the PCR, the question that they asked was, is it likely to be the patient having HIV, or is it likely that the patient will not have HIV? And the answer to that is, although the correct step is do PCR to actually confirm whether the patient has got HIV or not, but the likelihood of this patient having no HIV is very high because, as I told you, that HIV prevalence in many countries is very rare. We have 130 crore population in India, and we have around 2.4 million people who are infected. So the prevalence is very, very rare. That means if you look at 100 people, the number of people who have got the disease is very rare. If any test is positive, the chances of it being false positive still becomes quite high. This is the logic behind this idea, that if you have HIV-1 and HIV-2, you don't have antibodies against both. Obviously, next step is PCR. But even before you do that, you have an idea, chances are it's going to be HIV negative. The probability is very high that it's going to be ending up as HIV negative. So this is a very nice chart about explaining, particularly if you are starting acute HIV patient. What we saw earlier was a chronic HIV. Obviously, the testing module works even for acute HIV. But if you're looking at a patient who's coming with acute HIV, and let's say this is a patient who's coming post-exposure, and they're asking, I did not have, I had an unprotected sexual contact. Now, what should I do? Now, in this, between the point of infection and about 10th to 12th day, there's not much you can do to pick up the infection. By about 12th day, the RNA PCR starts becoming positive. So the earliest in acute HIV, in a post-exposed patient who will start showing the test that will start becoming positive, obviously, is the HIV RNA plasma levels will start rising. Then we have the fourth generation, and I was telling you that the fourth generation can pick up pretty early. You can see the gap between getting an RTA, the PCR, and getting the fourth generation ELISA becoming positive. The gap is not much. So this is a good thing for us. About by end of 2 weeks, we can have the fourth generation assay that we did earlier. I just showed you. That is the P24 antigen HIV1 2 antibodies combined test. That is the fourth generation ELISA we talk about. That is pretty early. It can pick up the patient having infection. This is because the HIV P24 antigen becomes positive very early. And I remember fourth generation assay test for all of them. So even if P24 antigen is present, it will pick it up and show positive. So that means the earliest to pick up the infection in post-exposed patient is the HIV RNA. That is by 12th day you can pick it up, and about the end of 2 weeks you can pick up the fourth generation ELISA can become positive. That is basically because of the HIV P24 antigen. The antibody takes some time. Earlier we were only testing for antibody, and that's why the window period was large. And if you remember, the first generation immunoassay that used to be there used to be positive only about 30 days or 40 days or 50 days later, and it would create a lot of anxiety whether the patient really has picked up the infection or not, and it used to be positive quite late. So this is the advantage of using the fourth generation assay. See how early it can pick up, and the gap between picking it up by RNA PCR and by picking it up by the fourth generation, the gap is very, very narrow now. So this is how early now we are able to, the window period which we used to talk about is becoming significantly decreased, and that's the advantage now that we can make the diagnosis of acute HIV infection much earlier. So to summarize once again, the sensitivity of the fourth generation assay, I told you the fourth generation antigen antibody combined assay, if it's negative, it's possible that it can be negative if you tested below the 2 week threshold that I was telling you for the fourth generation assay to pick it up. So that's the only place in acute HIV you have to be cautious. In chronic HIV, if this is negative, the patient does not have HIV. In an acute HIV, post-exposure, up to 2 weeks, the test might be negative, so you might have to repeat it. So that's one thing. If the test is positive, obviously, look for the differentiation immunoassay. If it is HIV1 antibodies are detected, the answer is HIV1. If HIV2 antibodies are detected, the patient has got HIV2. If both 1 and 2 are negative, then you have to go for PCR. If it's positive, then it's a diagnosed case of HIV. If it's, let's say HIV1 RNA PCR you do and it came out as HIV infection, then if you get a PCR negative, then it's not HIV, it was a false positive test. So this is simply the logic about how, in a very simplified way, how the CDC is recommending these investigations. Notice in this list, Western blot is not there. So the idea that we used to do earlier of ELISA followed by Western blot, that has been removed now. Okay, so this is generally the guidelines that CDC is recommending. The problem is because of cost factors, in certain places like in NACO guidelines, they are still inculcating the use of Western blot and other investigations. It's cheaper, but this is generally what they might ask in our exams now. So let's say we got the testing done and the patient was found to be HIV positive. Now this is a patient who's coming to us with the report. Now we have the report in our hands. This patient was found to be HIV positive, and now you have to do further investigation to manage this patient before you start the antiretroviral therapy. So what other investigation has to be done in this patient? So in this patient, obviously, you need to get a complete blood count done with differential count, obviously. Get a creat done because many of the drugs are excreted through the kidney. So we have to check blood glucose, LFTs. So these are typical routine investigation you need to do. And don't forget, we have to get the LFTs because some of the drugs are hepatotoxic. So obviously our decision of deciding what drugs to choose to a large extent depends on the reports that come when you get all these things done. So you get the complete blood count, the creatinine, the blood glucose, the LFTs, and one very important investigation is the HIV resistance genotype. Although we don't have to wait for the result to start our antiretroviral therapy, but resistance genotyping is very important now because there are certain patients who might have developed resistance or who might have got infected by a HIV strain which is resistant to certain drugs. So this is going to tell us the virus is resistant to what drugs. Okay, this HIV resistance genotyping, and also you can get a HIV viral load. So this is as far as the HIV load is concerned. Now the other investigations, you don't have to do it in the same visit. Subsequently in the future you can get other investigations which include serologies against toxo, against CMV, against varicella, okay, varicella IgG, rule out hepatitis A, B, hep C, okay, syphilis, then get a urine analysis done. If you plan to start a patient on abacavir, then HLA B5701. If you are intending to start the patient on a nucleoside reverse transcriptase inhibitor called abacavir. Obviously, rule out tuberculosis. Standard STD screening should be done. Sexually transmitted disease screening for gonococci, for chlamydia, syphilis, trichomonas. In a female, pap smear becomes important. So these are all additional investigations that can be done. But what is important is the ones that I've listed out first over here. This is definitely what you need to get done in a patient who is found to be having HIV positive. So you need the CBC, you need the creat, glucose, LFTs, resistance genotyping, and a viral load. You start with this. Then obviously I forgot one very important thing in this, and that is the CD4 counts, right? So you can add it over here, the CD4 counts. So these are all important investigations, essential investigations which have to be done the moment you have a patient HIV positive. This is minimum. This has to be done. The additional investigation that you need to do include all these. You get serologies. At least you have to maintain a file and document whether the patient has already got exposed to toxo CMV in the past. Remember, the problem is that many of these infections are dormant, in the sense you can have reactivation of toxoplasmosis and CMV, and these infections become a problem. So if the patient not exposed, then that is good news. If the patient already got exposed, then there's a chance that the patient can have reactivation of these infections. Urine analysis has to be done. HLA-5701 becomes important in patients who are going to be started on abacavir. This is because you can get a hypersensitivity anaphylactic reaction in those who have got HLA-B5701 if you use this drug. Obviously, you have to rule out tuberculosis. Sexually transmitted diseases, standard screening should be done. Pap smear should be done if it's a female. So these are all the investigations that are additional, but typically these are investigations you're going to get done first in a patient who comes out with HIV test positive.